Good morning. My name is Amanda. I'm with Apex Dental Lab Group, and I have with me Dr. Keith Tam and also Brandon Richards. Brandon is with Kinder Crowns, and Dr. Johnson as well. We're just working through a few kinks. I'm going to let Dr. Johnson share his camera here, hopefully, and we'll give everybody a couple minutes just to join. It looks like we already have quite a few on. Brandon, it looks nice and sunny in sunny Florida.
Yeah, it's going to get up to 85 today, which I think is
Nice.
Probably a little warmer than where you're at.
Yes, I'm in Wisconsin, and we're having a heat wave. It's like 30. Yeah, no, it was really cold before, but yeah, so just a little bit about Apex. Like I said, I'm in Wisconsin. We have labs all over the US, including Alaska. Some on the West Coast, some on the East Coast, several in the Midwest, including Kinder Crowns. And Kinder Crowns is located in Minneapolis. Brandon, do you want to give a little bit more, just a quick recap of how this webinar came to be?
Sure. So a couple of years back, we started discussing with Chad Davis, one of the founders, along with Drew Johnson, how we could implement an intraoral scanning system into the preparation for zirconia crowns to conserve tooth structure and really to make it easier to seat. They had partnered up with a company called SecoWave, who worked on the software development to create this system. And I'll let Dr. Drew kind of chime in a little bit more on that.
And before we'll let Dr. Drew chime in on that. Now, hopefully, Dr. Drew, can you hear us? Oh, there you are.
Yeah, I'm here. I was just waiting until later
No
on.
problem.
So, yeah, if we want to kind of chime in now. Yes, Brandon, thanks for introing it. And yeah, it was years ago. At this point, we were trying to find a latch point that pediatric dentistry could finally start benefiting from the same technology that me as a prosthodontist had been used to using for over a decade at this point, from intraoral scanning and milled restorations and all the things that we in adult restorative dentistry consider to be more standard of care now. The environment of the pediatric dental setting is a totally different animal. We have procedural efficiency factors and behavior management factors that just really aren't at play, not on the minute by minute basis they are for most pediatric dentists. So understanding a little bit more of what goes into the day-to-day for a pediatric dentist and understanding where the technology could actually help rather than hurt the daily productivity, the revenue flow, the patient management, the overall branding experience of your practice. I feel like we finally have a solution that may actually make sense for all of you out there. And yeah, I would just kind of pitch it over to Dr. Tam to speak more from a clinical perspective on that. But I look forward to taking you into the details, later on this morning on the software side.
Yes, thank you guys for kind of helping give a little brief overview as we wait for everybody to join. We're getting up pretty close to the total number of people that registered, so I'm just going to give it one more minute here while we're waiting. You probably already saw there is a poll that is live. It is a question. It probably popped up on your screen, but if it didn't, it should be down on the bottom. The question is, what is your background? And then there are 3 choices. And then Dr. Tam is going to use that a little bit as he starts his presentation. A couple of housekeeping things before we get started, and I can introduce Dr. Tam. The first thing is the CE. If you are looking for CE credits, this will be Apex will be providing CE for this. I will be sending a recording along with CE instructions out after, probably later today, possibly Monday. So please make sure you look in your spam filter, in your spam folder, junk mail. Sometimes they tend to go in there. So it should be subject line of recording and CE. And then I will include, the really important thing is that I will include a PDF that is a poll or like a survey. And at the bottom of the survey, we need you to sign it and fill in the code that I'm going to be giving today. And that is documentation that we need in order to provide the CE and through the PACE requirements that we adhere to. So if you have any questions on that, please reach out through the chat, or you can email directly at info@apexlabgroup.com. And it looks like our poll is, Dr. Tam, can you see the poll? Or no, I can read out the totals if you'd like, and give you
No,
an
I
idea.
can see it. You know,
You can see
this
it.
is really, yeah, this is really helpful. So I can kind of slow down or speed up in certain parts. So I appreciate everybody's candor in terms of getting an idea of what experience they have with pediatric zirconia crowns.
Great. So with that, I think we are at 5 minutes after, and I know Dr. Tam, you are seeing patients later today, so I don't want to keep you too long. I would love to introduce Dr. Tam, and then I will be introducing Dr. Johnson later. We're going to have Dr. Tam speak for about an hour, and then we're going to do Q&A with Dr. Tam right after that. He's going to speak more from the clinical perspective and as a user, as a clinician using the Alphabyte scanner. And then we will take a short 5-minute break, and then we will have Dr. Johnson speak around between 10:15, 10:30 Central Time. So that would be, gosh, my math skills here, 8:15, 8:30 Pacific Time, and all the other time zones, because I know we have all time zones joining us. So if you have any questions, again, please reach out in the chat. I will be monitoring that as we go. So I am done with all the housekeeping. And with that, thank you to Brandon and Dr. Johnson for joining here at the beginning. I know they will be turning their cameras off for now, but then we'll be joining again when their time comes. And Brandon with Kinder Crowns will be available to answer questions as well. So with that, Dr. Keith Tam completed his doctorate of dental surgery at University of Southern California. He went on to complete his pediatric residency at Boston University Goldman School of Dental Medicine. Dr. Tam started up his private practice located in Santa Maria, California in 2010. In 2012, he became board certified by the American Board of Pediatric Dentistry. Dr. Tam has placed thousands of zirconia pediatric crowns and thoroughly documented his cases over the past several years. With that, thank you, Dr. Tam, for joining us. I'm going to end the poll here and turn it over to you.
Great. Thank you. Let me close this. Can you get, can everybody see I'm going to move the Zoom video to the right just for a little bit.
Sure.
So everybody can see. Oops. Okay. So just like Amanda was saying, I'm just like everybody else in the audience in the sense that, I was very novice to doing zirconia crowns. And even when it started coming out in, I'd say 2011, 2010, they had, I think Tough Kids Crowns was the first set that I ever bought. And, coming from a East Coast residency, we're very comfortable with placing strip crowns in the anterior, and then 3M stainless steel crowns in the back. And so with something with as an alternative, as a cosmetic crown in the posterior, it was really exciting. Although, I had reservations about using it because I didn't think in my audience in Santa Maria, it's more of a middle income environment. And I was I am still a PPO doc at this time. And I didn't know if it was something that everybody, my patients would consider. But as time got rolling and I got to meet Brandon, and I was using the veneered crowns, metal crowns in the anterior, and he started carrying or creating Kinder crowns on the zirconia side. It got me all excited. And so, if coming with working with Chad and Andrew the last, I think, 18 months or a year, it's opened our eyes about how challenging it was in the beginning. And I think, as I'm continuing to use Alphabyte for a lot of different cases, I think it's going to be a lot easier to adopt this in your practice, or, just even get started. And for the advanced users, I would say, I'd be more of a Jedi Knight or, you know, almost a master, I'd say it does help because I've done it with Alphabyte, and then, you know, went without Alphabyte for a couple of cases, and it made me feel like, oh, you know what, there is added value to it. And so let me go through the clinical portions, and then we'll segue into, I'll let Andrew segue into Alphabyte and Chad, if Chad's going to be talking. And so just taking a step back again, you know, I really started doing zirconia probably 2015, 2014, 2013. So maybe 7-8 years ago. And it was, you know, nobody had any advice or guidance on how to do this and whether or not retention was going to be, you know, it was going to retain. And so, you know, when we look at the whole wide scape of type of cases that you're going to be considering, obviously anteriors are going to be far easier than anything in the posterior. And so if you were to attempt to do this, I think a single lateral, single central would be great. Although sizing it and making it look like the adjacent natural teeth is going to be a little more challenging with a single unit. But as you get to more units, it's gonna blend in that much better. But obviously placement can be a little more challenging, and especially when you have to factor in space loss. And then when you get into posterior teeth, you know, a lower first is probably going to be the easiest, obviously, to visually evaluate occlusion, you know, space loss, adequate circumferential reduction, those type of things. But once you start getting further posterior to the second molars, or even side by side, or with space loss and space and imposing crowns, you're going to be more challenging. I think that's where, you know, I even with a side by side case today, if you were to ask me if I were to use Alphabyte or not use Alphabyte, I would use Alphabyte at least for one unit. And then once I get that first unit, I can figure out the second unit pretty quickly. And I think Drew and Chad are working on the next iteration where side by side is within the horizon. As far as anterior crowns, we're gonna go through. Let me take a step back. I didn't put a table of contents. So basically, we're gonna go through anterior crowns, posterior crowns, full mouth rehabs, and then all my screw ups. And then you can see where I would say Alphabyte would help you avoid the screw ups that I made. A lot of them per se. So in anterior crowns, the big thing is about this is that, you know, we all experience in pediatric dentistry, you know, a lot of ECC and severe ECC, and sometimes it's four teeth, sometimes it's 10 teeth, sometimes it's 2 teeth. And so a big question is, how much tooth structure can I have left over? You know, if I place STF, what would happen? Can I block it out? And for example, this was a particular case, was a 2-year-old. We had a large decay on D and G. We previously treated with STF. And so I got the question oftentimes, hey, what happens if you can, you know, can this crown block out the STF and make it look cosmetic? And so you can obviously see I did place STF. It's all over circumferential around the existing tooth. And as we prep, I ended up having to do a pulpectomy. That was my axial reduction and incisal reduction. And then that was placement. Just to take a step back, I do use contoured crowns in the anterior, but I have transitioned over to universal crowns in the posterior. And it's Brandon can fill you in on more about the different sizes of crowns and even the custom crowns that he can do. But this is, you know, 2019. I'd say universals came in 2018, 2017 per se. I don't recall, but Brandon can kind of fill you in on that. So in any case, I went ahead and placed regular size D3 and G3 crowns. And then this was about 3 years later. I ended up having to do a crown on E later because that composite kept on popping off. And so you can see that even with those, unfortunately, I didn't take a post-op photo, but from a cosmetic standpoint, I didn't see any issues, and it didn't wash through, and you couldn't see the SDF color under the crown. This is single central. The problem with the single central is that you can place it very easily. It's just getting it to match the original tooth. It's very challenging because the crown is naturally going to be larger and more bulbous by comparison to a natural tooth. So this is a 23-month male or almost 2-year-old, had a trauma tooth F. I recommended to pull it. Mom was hell-bent on kind of trying to keep it. So you could see that the pulp was blushing right at us. And so we were luckily able to get her into the OR, or get him into the OR within a couple weeks. And this was placement. We placed a short crown just based on the emergent profile. And you can see on the natural tooth, you only see 50% of the crown, whereas when you place it, you're going to end up placing far into the gingiva. You're going to have to cut away a lot of the sulcus in order to get into placing it correctly. And then this is 5 months later. As you can see, I think it matches really well. If you were to stand back 6 feet away, I think it looks awesome. But if you're up close and personal, about up in his face, 6 inches away, you're going to see the difference in terms of the size of it. But I think from a cosmetic standpoint, I think it looks great, and it's a really nice restoration. And then the gingival adaptation of these zirconia crowns, it's far superior compared to the veneer crowns. Dare I say, even strip crowns. And then that was about 2 years later, and I didn't have to do a pulp on that tooth. This is a single canine placement. Again, this was a ECC case done in the OR. I get this question a lot, where when I was first starting placing these crowns, I did a lot of pulpotomies and I did a lot of endodontic treatment, a lot of pulpectomies. But over time, maybe it's because I just kind of figured out how much reduction there is in terms of the incisal portion or the occlusal portion, or, as well as Brandon refining the crowns where, he was allowing more clearance on the occlusion. I've been able to get away from not pulping every single tooth. And so this is a 3-year-old. Do you really have to pulp this tooth for reduction purposes? I can say most oftentimes I try to avoid it, and you can still place the crowns within occlusion without pulping it every single time. And we ended up placing this in 2019. It was a size 2. This is a universal. That's the axial reduction, about 1.3 millimeters all the way around. I'd say about 1.5 to 2 millimeters incisal reduction and singular limit reduction. And then that was a placement. I just happened to place a crown on tooth S as well. And then this is 7 months later, occlusion equilibrated. And that's about almost 3 years later. And so as far as retention goes in the anterior, I know we all stress out about losing a zirconia crown in the anterior. And I've heard of retention issues from other crown manufacturers or other crown companies, but in my hands, I haven't seen it. I've only had like maybe 1 or 2 that have popped out as a result of retention issues. And I think I have another case I can show you later on that I basically had no tooth left and I was able to retain it. And so this is I'll walk into that case in just a moment. Again, I'm going through each case, just letting you know how it can kind of match and how to kind of place it, and making sure you had the correct size. So in this particular case, it was in 2016, a 3-year-old, again, ECC again. You can see the radiograph, and also you can see that there's some collapse of space loss mesial to both E and F. And so I'd say keep that in mind, because as you continue to place these crowns, you can no longer adapt the crown like a 3M stainless steel crown where you can just kind of squeeze it with your fingers or squeeze it with a crown crimper. These ones you have to think out of the box, and I'll give you some clues on how to do it as we continue to go through cases. So this one, I ended up doing pulpectomies on them and placed size 3 crowns. These are contoured. The nice thing about kinder crowns is that they have both regular size, and then they have Brandon or Amanda, I'm sure you guys can remind me, but they have a short size too, which is about 1 millimeter shorter. Most users these days, I think, use the short crowns. I carry both. It's sometimes if it's a 2-year-old, I like to go longer because I have an idea. I mean, in my head, once they get to 4 and 5, the gingiva is going to continue to pull away, and I just don't want the margin to show. And so sometimes I want a longer crown. And so that was 12 months later. Looks great. This is one of my first few cases that I wasn't sure how it was going to come out. Those I did do pulpectomies on them, and then it's a little over 3 years later they exfoliated. I think I still see that patient today. This is a 3-unit. Again, coming from a aesthetic standpoint, I didn't know if a 3-unit would work and be able to match the untouched tooth. But this case came out very awesome, where this is the placement and the gingival adaptation, and then this was 1 month later. This was actually a referral from a general dentist, and the GP was very happy with the results, and was excited to see that we have this type of restoration at that time. The only thing I would change on this is that on D, I would probably take off a little bit more cingulum to just draw the incisal portion of D back by comparison, but E and F came out really, really nice. Okay, getting to retention. So this is the one case where, honestly, tell you, I probably would have recommended to extract it, but parents were hoping that we could save it. So I reluctantly went ahead and tried. And you can see 2D was basically at the gingiva. And when we do these cases, another GP asked me, hey, what kind of posting core do you use? I didn't use any posting core, obviously. And what I did is basically I went into the cingulum, and when you draw into the cingulum and do that circumferential reduction, you're going to get about 2 millimeters, maybe 3 millimeters of axial wall height that you're going to use to retain that specific crown. And as you can see, at least a year later, it was still there. And cosmetically, I'd say those crowns and the smile line looked awesome. And then this is about 18 months later, no, 24 months later, 30 months later, and it was still there. And I think it finally exfoliated probably right around 3 years. And so I think it's a mixture of the stuff, the cement, of making a thick cement, and also I want to give a little bit of credit to Kinder Crowns for placing the retention grooves on the inside, and just making sure your prep design and making sure it matches makes it work out really nicely. And so a lot of these cases that where you would probably typically extract, you have a chance of trying this. I'm not going to say it's perfect, but there's an opportunity to offer an alternative to your patients and your audience. So there was another question years ago, hey, can you use this on a 4-unit anterior class 3? And yes, you can. It's just you can't turn it into class 1. So this is the pre-op photos. These are the size crowns I use. This is an interesting one just because remember how I explained that sometimes you have space loss that you have to deal with, whether it's in the anterior or posterior. This particular one, sometimes I will use a lateral crown for a central crown just because I know I can gain a 0.5 millimeter or 1/4 millimeter of reduction axially and can fit the crowns all together. So oftentimes I will carry a size 5 or size 6 lateral crown and place it in the central because I've lost space, or just the teeth are naturally more narrow. And then this is 4 months later. Adaptation looks good. You can't even tell the laterals versus the centrals. And then that was about 34 months later. This patient actually moved. And so I don't have any post-op x-rays past 2020. Oh, right before pandemic. Maybe I lost them during pandemic. So one of the things that I usually always recommend when you are doing these crowns is I would try to just prep one tooth at a time, or contralateral teeth. So say, for example, if you were to prep D, E, F, G, I usually am I'm a right-handed provider when it comes to prepping, and so I start on my left side all the time. So when I do these particular cases, I usually typically prep E and G and compare them to the original D and F so that I can kind of get close to what I want it to be. Again, this is prior to Alphabyte, and I don't know if Alphabyte's doing anterior just yet, but this is just the way I figured out how to get close to the original teeth. And so you can see this is a very ideal reduction of the tooth. You know, I didn't have to pulp these teeth. And again, in this situation, I think, you know, this is years ago where, you know, this case had additional posterior teeth to fix in the OR. Even that class 3 there, I'd probably be hesitant to try to do a filling there because it's going to pop out. And so the only alternative that I have is zirconia. I wouldn't even bother a strip crown these days because I know strip crowns when you place them, they look great the first day you place them, but every recall later you're gonna have it chip, and it's just, what do you tell the parent? Hey, you know, are we gonna have to replace it again or just leave it? And so with zirconia, you don't have that problem. And then this is both together, and then this is cementation, and then this is what it looked like. I do check occlusion almost every single time with zirconia, and part of the reason why is you don't want to have too much hyperocclusion. Otherwise, you're going to get into a situation where they're going to have sometimes it dislodges the crown and you have washout, meaning that the tooth turns gray, or you have severe attrition on the opposing tooth, whether it's another restoration or a natural tooth. So biggest things in terms of tips, obviously pre-size if you can. It's much easier in the anterior. I like contour better for centrals. For laterals, you can use universal or contoured. And again, Brandon can go more into that. Multiple crowns, like I said, prep contralateral. Universal is okay. Space loss, use laterals for your centrals. Posterior crowns. I think posterior crowns is everybody's, how I say, it's kind of like the dark side per se, because it's not easy. You know, it's 20 millimeters past the anterior, and you're having to visualize and deal with not only a posterior adjacent tooth, but also an anterior, and deal with occlusion with the opposing. Whereas in the anterior, sometimes you don't even have to deal with occlusion. This is a 4-year-old in 2016, pretty large decay. We ended up having a pulpit and then placing at the time, we only had contoured crowns in the posterior, and that was what it looked like post-op. As you can tell in this particular case, I did have to reduce the opposing tooth S in order to get this to fit correctly, from an occlusion standpoint. And then this is 5 months later. That's a little over 2 years later, and you do get that radiolucency. I wouldn't, but typically there's no, there is a periapical radiolucency, but I typically don't see a sinus tract. It's pretty rare, but it doesn't mean I don't see it. So as far as first, this is 29 months later of the same case. So this is a second molar. The nice thing with second molars, if you can get, if in fact you do have one, if you have the first molar there, at least you have a reference guide of the mesial distal width of what you need to use. At the time I used as 2.5 size crown, and this was 3 months later. Honestly, to tell you, I probably would have used a 1.5 size crown, and you can see I oversized it. In this case, I did have to shave off a little bit of the mesial or the distal of B, in order to sacrifice a little bit in order to get the crown size to fit. I think in this situation, one is that I probably should have carried size 1.5 crowns. 2, I think Alphabyte would have been perfect for this, so that I would have not had to deal with oversizing this crown. And then this is 21 months later. Still looks great, but again, I think if you look at the relationship of size, I probably oversized it at that point in time. And then this is a lower first premolar, or yeah, lower first primary molar. My apologies. And we all get this where we try to do a mesial and a distal restoration, or you simply crown it. And in this situation, I ended up crowning it. This is a very ideal non-space loss case where I didn't have to pulp it. This is what it looked like from the occlusal standpoint and from the buccal standpoint. Again, 1.3, 1.2 axial reduction, and about 1.8, 2 millimeters of occlusal reduction. You can avoid the pulp. And then this is where it's at prior to cementation. It's a little high from my standpoint. If you look at the marginal ridge along the buccal of T and S, I'd probably say it's a little high, and I probably would have had to change the occlusion or reduce the occlusion on the opposing, which is B. This is the post-op. That's what it looked like. Oh, I ended up extracting B, so I kind of cheated. That all worked out. So they look great even after 3 and 4 years later. This is another case, and this is one of the cases that I've really realized that you can't, you have to think about alternatives in terms of space loss, as opposed to pinching crowns in the posterior stainless steel crowns. In this one, you could see that the margin, the mesial marginal ridge of tooth J creeped into tooth B. And so you have to consider, okay, well, I'm going to have to do a class 2 or crown that one too in order to make this work. And so you can see that this kid was a grinder. And so I had to reduce heavily in order to get to the right type of occlusion. And then you can see that the axial reduction, again, it's about 1.3, I'd say. I ended up pulping it. At the time I was using former Cresol. I've switched to MTA at this point. And you can see when we placed it, this was a contour crown, and you try to get as close as you can to placing this the right size, which was a 2.5. But keep in mind, when you place it, you really have to draw back that marginal ridge of tooth J in order to get it to fit. So by virtue of that, you know, it did have a class 2, but if it didn't have a class 2, you're either going to have to do some type of odontoplasty in order to get this to fit, or place a class 2. And this happens quite often. And, you know, I'm sure you as providers run into this all the time. It's just in zirconia, you can't pinch it. You got to figure out how to reduce the adjacent tooth and size the crown smaller. And again, the nice thing for Brandon right now at this point that he's provided for kinder crowns is that he has half-size crowns. And I find that I use half-size crowns more than I use regular size crowns. And even when Alphabyte puts together a lot of the and gives you an idea of the size, I find that it gives back half-size crowns more often than full-size crowns. This is 2 months post-op. That's what it looked like, 7 months. And then at 22 months, it started exfoliating. This is a side-by-side I did back in 2016. Again, this was S&T. We ended up pulping both because of the proximity to the pulp. I use a rubber dam still all the time. Again, I usually end up having to take it off when you have to prep tooth T. And you can see way back when we only had contoured crowns, the reduction is pretty aggressive. I think the biggest thing to identify in this particular case is that you have about 3 millimeters of space between S and T, and that's how much you really need to reduce. Even today, even with the universal crowns, I'd say it's a little bit less, and it's a little bit more forgiving, but this is pretty close to where you're supposed to be on a side-by-side case, even with no space loss. And this was cementation. And this would also, Alphabyte's also going to help you, and even an X-ray will help you in terms of correctly placing the second molar. And I can tell you why sometime on the next case. But on this case, as you can tell, I ended up doing pulpotomies. I started getting some radiolucency on the distal canal of tooth T, but there was no sinus tract. So I oftentimes in these cases, I ended up just monitoring and just letting the parents know in the future we may have to extract this crown. And then this is about 4 years later. You end up getting premature eruption of tooth number 29, and that again, for the Padawans or the beginner users, this happens quite often. This is a side-by-side case. Again, this one had space loss in 2017. I ended up using size 4 crowns for both. And when you're doing these side-by-side, units, you're going to be aggressively reducing the teeth. Almost basically, you're violating the biological width at this point. And I am getting some cases coming back where I'm having some issues. But again, there's some tips that you can choose to use to reduce the chances of failure and end up having extracted teeth. Luckily, in this case, I think this case worked out. There was some reported pain later on, and then we took an X-ray. Radiographically, I didn't see any periapical lesions. It turned out this particular case, he actually had MIH, a pretty severe form of MIH, and we ended up having to send him to the oral surgeon to extract all 4. He's actually going in to get an ortho exam with us. We have an orthodontist with us now, and he's going to go through ortho soon. Nice thing about
Dr.
this case.
Tam, sorry to
Yes.
interrupt you. I just wanted to let you know that we will be providing more information on the different crown options at the end of the CE
Okay.
as well. So Brandon can do that. And then I did have one question that came through for you.
Okay, sure.
What is the preferred cement choice for preformed zirconia pediatric crowns?
So I started playing, I've used Keytac the whole time, the old school, you mix it on a pad, because I like it to make it thicker, and I'll show you on a slide later on. I tried out Fuji recently, the pink one with the clicker. I just forget which one it is, but it's too, what do you call it? It's too wet. And I ended up having to swap it out on the same case when I was doing oral sedation, and I didn't feel comfortable with placing it because it was too wet. It has to be a thicker mix for it to set correctly and to get better retention.
Thank you.
No problem. So moving on, let me get back to the slides. So again, this case, it went the distance. I wonder if I have a post-op. No, I don't. I don't have a post-op with that case after that. I'll have to update this one because I know I have a newer X-ray of this one. So oftentimes, like I mentioned, you kind of have to think out of the box in terms of sometimes you have to, in this case, at the time, we only had contoured crowns, and we all run into that heart-shaped L or S, and this happened to be a heart-shaped S, and I ended up using I guess a contour upper eye for the S. And so this is what it looked like afterward, and it works just fine, and it came out really nice. The only downside is that you can see that I'm getting some internal resorption, but to get it to last past 4 years and not to have a sinus tract, I think it served its time, and it did a good job being cosmetic and also keeping itself as a placeholder for the next tooth to come in. So posterior zirconia tips, again, pre-size, if you can consider the Alphabyte system, I think it'd be awesome. It makes placing posterior crowns so much easier. Again, you can substitute. When you do some type of endodontic treatment, you can reduce more. It alleviates occlusal interference, but nowadays, as the rest of the pediatric dentists, we're all trying to pulp less, basically, to ensure better success. And you can do that with kinder crowns. It's not, the occlusal reduction is not that severe. You can get away with it. Second molars, if you can use anatomic landmarks to get a guide and reference, sometimes you get some mesial tipping. It's okay. It does equilibrate over time. It just stylistically doesn't look great. And I'll show you some cases later on my screw-ups or my lessons learned experience.
Speaking of lessons learned, sorry to interrupt you, Dr. Tam. I
Sure.
just was alerted that the chat was disabled, so I apologize for that. If you have questions, I have enabled chat now for everybody. So if you
Okay.
have questions, please do put those in the chat. Thank you for bearing with me, Dr. Tam.
Yeah, no worries. Yeah, and if anybody has any questions, by all means, just go ahead and ask it, and I'll try to answer it at the same slide, because I'd rather answer it right then and there than go slides down and forget about answering, or having a participant not being able to remember asking a question that's
Agreed.
pertinent to the slide that we're on.
Thanks.
So consider prepping 1 molar at a time. Again, you're going to get more occlusal interference when you have less endodontic treatment, and you're going to have to end up if you want better or less occlusal interference, you're going to have to sacrifice the opposing a little bit, maybe a 1/4 millimeter, maybe a 1/2 millimeter reduction, not too much, but just enough. So these are full mouth rehab cases. This is maybe this was probably a year or two into doing zirconia that I felt comfortable, and whatever came through the door, I said, okay, let's try. And this was a pretty awesome case. Again, I don't fault for any pediatric dentist that would want to extract DEFG. It's just this case, the parents were open to the idea of fixing it. And you can see there's no periapical radiolucency on DEFG. And again, this is very similar to that one case where I had 4 units in the anterior, and it was just D. And I guess I got a little more brave on this case. I haven't seen something like this happen very often, but this is what happened in 2018. This is what it looked like. Again, I used a combination of contoured crowns, a lot of short crowns in the anterior, and a half-size crowns in the posterior. And you can see the emergence profile. I was able to get a really nice occlusion and anterior profile. This is 3 months in. This is almost 4 years in. That's what it looks like. By the time last year I saw him in November, he exfoliated E and F. And so for anybody that is concerned or hesitant about retention with specifically kinder crowns, I can't quote you on any other crown because I haven't placed it. I've had really good luck on getting these crowns to retain and also go the distance. And I wouldn't say I'm up there with like any of the awesome pediatricians, but I think I do okay, and I think you can do it too if you continue to work on this and gain that experience. This is another case. This is an STF case where we placed SDF in the anteriors in 2018. This particular case, at the time, this is when Brandon was starting to roll out more. I think you were rolling out more universal crowns. Was it 2018, Brandon?
It was 2018.
Yeah. So this is where it's a big question whether or not universal crowns would be acceptable in the posterior. And I think this is a case where I ended up using I used a combination of universal and contoured. And so on the lower right side of the mouth, on S was a S5 contoured, and then T was a universal. And the opposing side of the arch, K was a K6, and then L was a universal 5.5. And so for anybody that has questions of whether or not they should use contoured versus universal in the posterior, I think you can get away with doing universal and it'll come out really awesome. And that's what I use today because I don't find that in certain situations, I'd say the upper first molar may benefit from having the contoured ones, but beyond that, universal is great for the posterior as well. And then this was 12 months later. I am getting some radiolucencies here and there, but again, oftentimes I just monitor and wait to see if there's a sinus tract. And by this time in 2019, I've been using a lot of MTA pulpotomies. And so for anybody who's asking former QSL versus MTA, honestly tell you, I have, it's about the same success pattern. I thought it was formal that was I had some failures on, but let's look at the cases as we continue to go on. This is an oral sedation case. The interesting thing about this case, again, this was another STF treatment prior to actually doing the treatment. And you can see that it involved a lot of the first molars and one anterior tooth. On this case, I would not recommend doing more than 1 or 2 crowns in a sedation, in an oral sedation. And I use the triple cocktail. I get a good hour of treatment time. It's just a lot of work to place these crowns. And so if you're thinking about doing oral sedation with zirconia, don't do more than 1, maybe 2. I end up having to split this case up. And this case was interesting in that when I placed it on the first sedation, on the first sedation, is this the first sedation? Yes, this is the first sedation. You can see I was high on BNI by a good amount, and I wasn't happy with that. By the second sedation, this was let me take a step back. I think the first sedation was on the right, and this the post-op photos, and then the right side, it was this area right here was the second sedation. You can see I was high right there. And so when we came back and we saw her 6 months later, it actually equilibrated. And so I hesitate to say, but even if your occlusion is high and you have 2 opposing zirconia crowns, and there's nothing you can do to, unless you have to you can replace it and further reduce, then you can get it to equilibrate. And one of the other tips that you can do is you can take a red diamond or a fine diamond to reduce the margins of the crown. And I have done that from time to time to alleviate occlusion issues and get the crown to seat further. It's typically on the buccal and lingual margin of the crown. Brandon would probably recommend a similar type of reduction on the margins as well, if you run into that situation. And then this is about 2 years later. I think we only did a pulpotomy on one of the teeth. I think it was tooth I. And then this is another oral sedation case. This happened to be a hygienist kid. And again, we tried to use SDF, tried to use glass ionomer to hold things together until we had to actually treat. And this was done during oral sedation. Unfortunately, I mean, this kid actually had like class 3 or class 4 tonsils. So it was actually a very stressful sedation. Not until she actually got her adenoids and tonsils treated by the ENT later, and she sounds so much better. But we were able to get all 3 crowns done. I ended up having to do a pulpectomy later on tooth L. The hygienist thought there was a sinus tract, but there wasn't. The tooth was actually vital after removing the crown. And then this is about, almost 4 years later. And so everything looks good. Again, some of the crown placements I would have taken off. I don't know if that's cement on the distal of tooth B or maybe the margin of the tooth. I could have probably placed that a little bit better. The only reason why I'm sharing this case is that this is an enamel hypoplasia case. I placed it in 2015, very early on. This is one of the case that I thought I was going to give up on zirconia because it took me almost 3 hours to place all 4 of these crowns. And to get into proper occlusion, again, if I had Alphabyte back in 2015, Chad, Andrew, it probably would have came out better. And I've probably been more confident about this case. And so you can see, I did place them and they went the distance. I probably oversized them based on, if you look at the adjacent teeth, it's just way too big. And I probably would have redone it with smaller crowns. But again, this one lasted over 5 years by that time. And she ended up going to ortho recently last year. This is a custom zirconia crown case. And Brandon has the capacity because, Kinder Crowns is part of Apex Dental Lab. And they're able to do custom zirconia crowns if you need to. And it just happens that I still see several, I'd say adolescent and adult special needs patients. And so these parents, this patient with cerebral palsy sometimes is a little combative with his dad, and he ended up breaking one of his anteriors. So we took him to the OR. We did a huge composite. We broke it again. Ended up doing a direct poke cap. Broke it again, and then I ended up doing endo in 2018 in the OR because of an abscess and repeated trauma. At this point in 2018, I told the parents we probably should just extract it because there's just no compliance, and I don't want to have to go back and fix this every single time and go to the OR. It's just a lot of money, a lot of effort for an anterior tooth. But the parents were imploring us to try to fix it, and so I talked to Brandon about this back in 2018, and with the help of RDA scanning and me and the parent, and I think there was one other person in the room hugging the kid, we were able to get some sort of a scan. And then at the time, Brandon and Todd put together 2-3 crowns to see if it'll go. And then this is the prep and post-op. And then this is, I probably would have cemented it a little farther gingivally, because you can see a little bit of the margin on the facial. And then I lost this kid during pandemic. And then he ended up finally showing up in 2022, and it's still there. It doesn't look perfect, but it's still there. And so, is this a benefit to your audience? I don't know if you guys still treat special needs. I don't know if you're comfortable doing this, but if you need a custom case, this is I think Brandon has a golden ticket to be able to make this happen. And again, at the time I only had iTero. I say the iTero scanner, it's a little slower than what Andrew and Chad have put together with Alphabyte. I think that scanner is a little bit faster. It's much faster in terms of scanning. And if we could do this with that case, it probably would have gone a lot faster. Okay, learning lessons. So we're going to go through burr selection, cement choice, what to do with cement leakage, sizing issues, outcomes of incorrectly seating crowns using Alphabyte, endodontic treatment of primary teeth. So burr selection, Kinder makes a great set. I just happen to use Blaster for so long, and this is the burrs that I use. I use the 8-round ball almost all the time for posterior, for occlusal reduction. Yes, you can use a pancake. You can use a football. I just happen to use the 8-round just because if I have to end up pulping it, I try to end up pulping at the same time. So I can, and then also sometimes because I use a rubber dam, I try not to catch the rubber dam to get it to fly or to rip the rubber dam at the same time. And then I use a short diamond and also a long diamond for axial reduction. Key tech. So that's what I use. I've been trying a couple other things. This is one where you can manipulate. This is one cement where you can manipulate how thick it is or how light it is. And I'd say if you were to mix it and you had the middle type of mix, that's okay, but it's going to take you longer to let it set. When it gets kind of furry, when it gets kind of stringy, that's where I kind of like it. That gives me about 15-20 seconds before it hardens. Cement washout. When you use a thicker cement, and try not to spray the cement out right away, you can manipulate it with an Explorer, which is what I do now when it's wet, just to draw out the excess amount. You're going to have less chances of this cement washout and showing through. And this is a case where I ended up doing, I think, 2 or 3 zirconia crowns, and I was in a hurry again. This is during oral sedation. If you were to do these, keep your behavior management really aggressive if you plan on doing zirconia crowns. So if you have 1 crown, maybe nitrous, maybe oral sedation, 2 or 3 crowns, you may want to consider general anesthesia at that point. This is what it looked like in the anterior. I did give the parent the option to replace these if necessary. She's cool with it. You can't see it in the front. And I think she ended up going through an ortho exam recently. And then the question came up recently, years ago, hey, can you take these crowns off? And yes, absolutely you can. Just make sure you use a fine diamond and with a lot of water. And this was one where I placed 2 anterior crowns on E and F, did pulpectomies, looked great 1 month later, didn't look great 3 months later. And so I ended up having to replace it. This is what it looked like with the crown off. And I like the fact that with zirconia, you get a really nice crown adaptation along the gingiva, and it heals really nicely, facial and lingually. And this was the prep. This was cementation. Sorry, the photos were intraoral camera at the time. But this was, let's see. I wonder if I have a post-op with that. No.
Dr.
I
Tam,
don't
we
have
had
a-
a question that came through.
Sure.
From Patrick Ruck. Did you temporize the perm anterior tooth prior to sending it out to the lab, or was it prepared and cemented the same day?
Are you talking about the anterior crown, or are you talking about the custom crown? Are you talking about the custom crown?
Let me see if he'll reply here. The permanent anterior tooth prior to sending it. So
So the question was,
did you temporize the permanent anterior tooth prior to sending it out to the lab, or was it prepared and cemented the same day?
oh, okay. So what happened in that case was that the patient already broke the tooth when at the time of doing a composite buildup and the endo. At that point, I just temporized it with some a glass ionomer, and then I did the scan from whatever or prior to placing glass ionomer, I just did a scan with the iTero, and we sent it off to Apex in order to prefabricate 2 or 3 crowns, and then I temporized it with a glass ionomer, and then I had the crowns available prior to going to the OR, and so I didn't go twice to the OR to get an impression and then
Sure.
place it. It was it was a lot of hard love with that boy, and so we had to do the scan as best as we could. And I think Brandon and Todd were able to pull it off.
Got it. And when you reference Todd, that he's with Apex, are
Yeah, Todd Macklin. Yeah,
Yep,
I think
exactly.
he's enjoying his cabin right now.
I think so. Yes. Thank you.
So yeah, I don't have the post-op photos on that one. So I did, but I don't know where it is. So anyhow, getting back to excess cement. So this is something that I was recommending prior, or some clinical trials recommend prior, is to let the cement set. I think after doing this so many times, and with the amount of thickness of cement that I was using in KeyTac, I no longer recommend letting it set right away and not touching it. I would definitely recommend at least starting to wipe off the excess with gauze or with an Explorer, start flossing a little bit, because I started getting a lot of cases where I had excess cement under the crown and I was unable to clean it out. Nowadays, if I still do see that, I probably try to use an auto scaler, but it's still fairly sensitive. And the problem with it is that you end up getting a lot of periodontal inflammation and periodontal recession, not only tissue, but also irritation, but also bone recession. In a long-term perspective, is it going to affect the premolar? Probably not, but it's more of a stylistic issue. I'm not happy with the parents not happy, and the kids irritated with the excess cement. So I ended up having to take this out, replace it. I ended up using a little pen laser to cauterize and sterilize the distal tissue. But again, this is a posterior tooth where I ended up taking off the crown with a fine diamond. And yes, you can take it off. It's not hard, and I ended up replacing it later on. And that's what it looked like post cementation. I don't have a follow-up with that case. Oh, here, I guess sorry, my slides are out of order. So this was the prior case where I took off the anterior one, and that was 18 months later. And you could see once I re-cemented and I had a thick set of cement, it worked out really nicely. And it lasted almost 20 months, or 24 months, actually.
Another question just came through.
Sure.
Dr. Tam, do you or your assistant scan for the prep of the crown with Alphabyte?
So typically I'm the one who does it, just because it's such a new product in our office, and so I haven't delegated that duty yet. But I know that Dr. Davis does train his DAs to do that, and you can absolutely train them to do that. That's not a problem. It just happens that when I'm in the oral sedation, when we sit down, we numb up, I'm not leaving that patient because it's, technically they're sedated. I have to monitor at the same time, so I'm just scanning while I'm doing it to begin with. So,
Sure.
but yes, this is definitely something that you can allow the RDA to train the RDA to scan. And I think that would save time, doctor time, to allow you to go do other stuff really quick and come back. If it were a nitrous patient or a GA.
Thank you.
In the anterior crowns, so heme pellets, or so with washout, sometimes washout cement, sometimes a lot of people worry about heme getting into the crown and trying to reduce the amount of heme that you get. And there's several different modalities. You can do ferric sulfate with a cotton pellet or with a gauze. Brandon has heme pellets that you can place. You can use a laser, or you can place a little bit of local anesthetic with epi just to slow down the bleeding. This is an option that you can try with what Brandon has if you're worried about it, using the heme pellet. Nowadays, honestly, to tell you, I don't get too much of a problem. What I usually end up doing is using gauze and holding it there. And I just time my crowns where I end up prepping a lot of the anterior work in the very beginning of my case, and then I don't seat it until the end. So I allow for whatever hemostatic agent or any type of pressure to get the bleeding to stop. So sometimes I don't place the crown right away after I prep. So that's what it looks like. The heme pellet actually helps really nicely. I just haven't been using it lately, but I did use it when Brandon first had it come out. And that's what it looks like, cementation. This is another heme pellet case, and it looks much better after placement. It's not perfect, but I can tell you, if you do use the heme pellet, don't use anything else. Don't try to add ferric sulfate on top of it. You will get some tissue necrosis, and it'll take about a week or two to heal up and look better. So that's just based on my experience. Don't mix the two, epi and ferric sulfate. I don't think it's a good idea. Sizing issues. Consider buying sized. Let's see. What I'm trying to say in this situation, try to have a full complement of crowns. This was prior to universals. Now that I do carry several sizes of crowns, and even in this case, I ended up using I think a 2.5, and it was still too big. And this is a prior case that I explained where the crown size, it could have been made a little bit smaller. Nowadays, I probably would have used a universal 1.5, or even I don't know if it has any sizes smaller than 1.5, but this was 26 months and it still lasted. It just stylistically, it probably could have been a smaller crown. And this is another clinical pearl, is that sometimes I will switch to a D crown in order to get both crowns to fit. And so this was done in 21, and that's what it looked like. It's actually 2 D crowns. I think I don't recall what the D sizes are. The D size crown placed on a second molar, it will be more bulbous. And so you will have more occlusal issues. So you have to keep that in mind, that you might have to seat it further down, or you may have to reduce the margin in order to get this seat correctly. And then space loss in the anterior, again, use laterals for centrals. Like this case, this was one that from the very beginning, I thought this was going to be a slam dunk case. Looked great on pre-sizing of the 2 contralateral crowns. This is the prep design. That was cementation. I was not happy. In retrospect, I probably would have used laterals for the centrals, and that's what I would recommend to you. Tight contacts, if you don't have the option of using laterals, you can always use a little slight distal rotation to the end, to the centrals, to get it to fit. And that's what you could do, but it's just going to look a little taller compared to the original. And then second molar placement issues. At the time, we didn't even have Alphabyte, and if you do have Alphabyte, or you're going to try it, or take an X-ray, sometimes you'll get some mesial tipping of the second molar when you place it. And this is one where it was opposing a stainless steel crown. This took 2 nitrous appointments and 1 oral sedation later. It was a rough case. And you can see that it was hyperoccluded, and I wasn't happy with it. I told the parent we can replace it. There's no charge for that. Parent said, it's okay, they're not in pain, let's just monitor it. And this is what it looked like 2018. I actually saw the kid a couple days ago. They're obviously exfoliated at this point, but they don't have any lasting occlusal issues beyond where the crowns were placed. Again, this comes back to proper placement. And again, this is one of my first few cases that I ran into, and I thought I did a great case. I chose to do a zirconia crown on the tooth eye, and I ended up doing metal crowns on the rest of the posterior teeth because it wasn't in the smile line. What I didn't realize is when I placed them, I didn't properly seat it down correctly, and tooth eye was super occluded by at least 1.5 to 2 millimeters. So this is why I'm telling you, with occlusion, you got to get it pretty close, especially if you are proposing a restoration that's softer or not as hard as zirconia. So with 2 zirconia crowns, you probably can get away with it. But if you have a zirconia crown and composite, a zirconia crown and a metal crown, you're gonna get a tuna can opened up like this I'd say that the CNC crown looked like a tuna can at that point. And this was because of improper placement of the crown. And so keep in mind, when you seat these crowns down, make sure it's the right size. Make sure you're adjacent to, there's proper space between 2 side-by-side crowns. Even if it's a metal and a zirconia one, it's going to be 2.5 to 3 millimeters. And that was a learning lesson that I had to deal with, early on in 2015.
Sorry to interject one more time. I just wanted to make a follow-up note on that prior question. Be sure that I know in different states there are different laws about assistants taking final impressions, and whether or not Alphabyte falls within that definition or not. Dr. Johnson is going to address it a little bit later as well, but my only note is to be sure that you follow state laws, of course. And no, the question that was asked Dr. Tam, if the RDAs can take impressions or not. So
I don't know if it's technically a final impression.
Right. I mean, technically it's more of a 3D intraoral camera.
Yeah, it's a scan
to help visualize the solution in real time. But I just wanted to make that note that I know, for example, in Texas, the assistants can't take final impressions. So Dr. Johnson will address that a little bit more later as well.
Absolutely.
Thank you.
So getting back to zirconia, a lot of chatter came about on I forget which I think it's Dental Town or wherever. People talk about stuff about, pediatric dentists talk about zirconia crowns online. So basically, we're getting a lot of, I was getting a lot of feedback, and I was experiencing myself where you're getting a lot of negative reactions to zirconia, or at least that's what I thought to be the case. And this was one in 2015 that we did in the OR, and this is what it looked like later on, years later. And you can see the radiolucency on tooth L. It didn't look great, and the composite came off, the mesial composite came off with tooth K. And then my business partner, he ended up placing a CNC crown, and at the time, I can tell you we're using Formo and Tempit. And this particular case, it kind of explained to me that it's not whatever medicament that's in there. Or it's a medicament. It's more like the medicament and the prep design. It's not the crown. And so we both cut dry at that time, and we're both using Formo and Tempit. And so since then we've changed to MTA and just bleach and a pellet. And I would say most oftentimes, like 99% of the time, I realized after doing these cases, this particular kid just may have some type of immunologic reaction to any type of endodontic treatment. But on the same token, I end up 99% of the time cutting wet. And so when you place these crowns, or when you're prepping for zirconia, I would highly recommend cut a little wet. You don't have to use a lot of water, just enough to cool the tooth down, because you are doing a severe aggressive axial reduction, and you are invading the biological width. And keep that in mind, you're going to be pretty close to the pulp. And this is the same story on this 2015 case, where you can see that there's a severe decay on the lower posterior teeth, and you can already see that characteristic sign. I think people called it ghosting or ghost tooth or whatever. You're starting to see, periodontal PDL widening, a lot of radiographic failure, and that's what it looked like about 2 years later. Didn't look great. I told the parents we can extract and put a space maintainer, but we can just monitor since there were no sinus tracts. That's what it looked like. I actually ended up having a fracture on the distal T. I think I had it ever since the beginning. You can see it in the 2015 or in 2016 x-ray, and it actually cracked on the distal, but parents didn't report back any issues. And then I got really lucky on this case. In 2020, everything exfoliated. So I'm not proud of this case, but it was a learning experience where you have to be careful about how much you're reducing and how much heat you're giving, you're introducing to the tooth. I think that's the long story short about these type of cases. Do I still get radiographic failures with like pulpal treatment or endodontic treatment? Yes, I do. But more likely I have higher successes than losses. That's why I still offer zirconia crowns and endodontic treatment today. Okay, so using Alphabyte, I think one of the big take homes for this is that it's a work in progress, but it's doing great things. And this is a particular case. I don't recall correctly what size we used. It predicted it was close to a size 4, and I ended up submitting a size 4 crown. This is what it looked like on the pre-scan, and this is what it looked like on the post-scan. And so you can see, as an experienced user, I didn't see, how do I say this? I know that when I place single unit crowns, I know that I'll end up having to use 2 or 3 crowns. In this particular case, I only had to use 1, take out 1. And this is, by the time I've used this is probably my 50th crown, 50th, 60th crown by the time using Alphabyte. And I ended up using, not using Alphabyte for a few more cases after this. And I realized how much more easier it was, even as an experienced user, using Alphabyte to help pre-scan and help guide me in terms of visualizing what I was trying to attain. And the nice thing about Alphabyte, I'm showing you just pre-op and post-op. It actually has a scan feature where you can see if your crown's not seating really well, it'll tell you where areas where you can, it'll suggest you areas where you can reduce. This is another case, tooth J. This is in clinic. No, was this in clinic? No, I think I used this under nitrous. My apologies. I think I wrote this incorrectly, but this is tooth J, and it was a 1.5. And you can see that there's a mesial drift of tooth J. I ended up having to do a composite on tooth I anyhow because there's class 2 there. And then this was cementation. So the 1.5, compare this to the other oversized crown that I did with the 2.5, no question. I would have, the Alphabyte would have helped me visualize and make it so much easier and less stress involved when placing these crowns. So one of the things that I don't know if the advanced pediatricians do this, I'm sure you'd probably do it, but for more of the beginner users, please do consider, if you are placing these crowns, you really have to bring up your A game in terms of your pulpectomy technique or your endodontic technique. Whether it's indirect pulp caps or pulpotomies, what pulpotomy choice you use, pulpectomies, posterior pulpectomies, or even triple antibiotic. I think I sat in a triple antibiotic session. Somebody did it with CSPD about a few months ago. Mixed success. I'm not, and even for me, I've used triple antibiotic on other cases, on a lot of avulsion cases, permanent teeth, or pulpal regeneration. I don't know if it's any better than calcium hydroxide in those cases. And I'm reluctant to say that it's that great compared to what I have experienced in pulpectomies. And so I got introduced to this from a mentor in Santa Barbara. His name is Dr. Ruby. So this is what I use today for posterior pulpectomies. I use hand files, bleach, Home Depot brand if possible. I'm kidding. If you want to use use a dental brand, that's fine too. I think Vista has a great sodium hypochlorite that I still use as well. Medium, of course, paper points. Endomotor is optional, but I find that as I get older, rotary is really nice. And then I used Diapex or Vitapex as a filler, and then I'll use Tempet or IRM on the orifice. And then this is when I started doing pulpectomies on tooth T. It was basically into the pulp. And then this is a post-op about 2 weeks later. You can see that there's some radioelastity in the furcation and also in the distal canal. And this is 2 years later. So this is what, all the published reports at the time didn't make me feel confident about using this as a viable technique in prior practice. But again, this is another case that I did for a GP's patient, and she sent me the x-ray back, and this is what it looked like, and it came out awesome. I was very, very happy with how it came out and how it looked. And I think at the time I wasn't using rotary. It still looked okay. But basically, I think that rounds up my learning lessons. Use diamonds if you can. Thick mix. I wouldn't. I had to change that line where I'd say start manipulating cement to get off the excess. Just don't spray water right away, because that's when you're gonna get more washout. What to do about cement leakage? You can cut the crown off if you need to. Sizing issues, again, keep in mind when you have space loss or crowding, you're gonna have to half size or size down a crown. Again, Alphabyte's gonna help you with that. It's best to have a full set of anteriors and posteriors. You may have to do selective odontoplasties on the adjacent teeth or opposing teeth. Use laterals for centrals. Try to use an X-ray if you're worried about cementation, if you can. But again, if you get better at it, or even if you consider Alphabyte, I think that would help reduce the problems with cementation. And then endodontic options, just use water when you're prepping, and then make sure you have the correct endodontic diagnosis. If you're not comfortable with pulpectomies, learn it. In this case, you're going to be able to save more teeth than not. And the goal is to have a great space maintainer in that spot for that child. Whether it, in my experience, I feel like having seen so many unilateral space maintainers fall off, I'd rather have a crown there if I could get away with it. And so make sure your A game's on, or just your diagnosis on. Some teeth we can't save, but that's how pediatric dentistry goes. You end up pulling teeth that you can't save. So, but that rounds it out.
Thank you. I was just going to make a note to keep an eye on time. I know you have about 15 minutes left before your patient. Thank you. Those are really cute pictures. Oh my goodness.
So that's who I have fun with all the time. So,
Exactly.
But anyhow, any questions, any concerns?
I don't think I saw any other ones coming through. Let me just double check. No, but if we have any other ones, we'll follow up with you on that. And thank you so much for your time, Dr. Tam. I will turn it over. Actually, let's take a quick 5-minute break for everybody. And then if that sounds good, Dr. Johnson, you can start in about 5 minutes. Thank you, Dr. Tam.
Thank you. Appreciate it.
Bye-bye.
Yep. Bye.
And I'm going to give a 1-minute warning here for the restart with our second half of the program with Dr. Johnson. So we'll start in about 1 minute. Hi, Dr. Johnson.
Hi, how are you? I've been here the whole time, but you haven't seen me
I
in a
know.
while. You want me to start sharing my screen now while we're waiting on the
Yes.
return?
Yes,
Okay.
please. And if there's any issue, okay, there we go. Yep, I can see your screen.
Full screen now. Should be fine now, right?
Yes. So let me grab one thing, and I think we'll go ahead and resume. And before we go forward, I just wanted to let everybody know that the CE code for today, I will announce it at the end of the program as well, but it is TJ 02. Sorry, I can't read my own writing. TJ0210. Again, the code is TJ0210, and I will record, or I will announce that at the end as well. And I'll follow up with instructions on what you need to do with that in order to get your CE credit. So I think we're ready to go with Dr. Johnson. Dr. Andrew C. Johnson completed his dental laboratory technician and prosthodontic training at the UTHSC in Memphis, Tennessee. Along with his board certification in prosthodontics, Dr. Johnson earned a postdoctoral master's degree in dental science, researching CAD/CAM restorative techniques and emerging digital dental materials. Alphabyte was originally conceived in 2019 by Drs. Andrew C. Johnson and Charles A. Davis, Jr. by combining the CAD/CAM capabilities of contemporary prosthodontics with the clinical efficiency requirements of pediatric dentistry. By providing real-time automated crown size selection and preparation guidance, Alphabyte is the world's first digital solution for pediatric and special needs dentistry. The patent-pending Alphabyte software application was developed through partnership with PsychoWave Health Solutions, KinderCrowns, and 3Disc from software development to clinical componentry to hardware integration. And with that, I will turn it over to you, Dr. Johnson. Thank you for joining us.
Hey, thank you. And thanks for everybody out there that's interested in this and paying attention to this and back from the bathroom break. So hopefully we're still talking to somebody out there. And I'm excited to explain this. And I
just wanted to let you know we have quite a few people on, so we're talking to lots of people.
Good. I'm not just talking to you in the webcam. Okay,
right.
This is great because Dr. Tam did a really good job kind of taking you through like the actual, like, you know, in the trenches pediatric approach to zirconia crowns, his whole journey through adopting what essentially is a more desirable result. At least most of the parents, myself included, would probably prefer that my child have a white tooth, not a metal colored tooth whenever possible. And, you know, the most durable, aesthetic, biocompatible alternatives to the traditional approaches generally should be preferenced over, you know, last century's techniques when it makes sense to do so from all the different angles. So we hope that, you know, the approach to conscientious care with the most important patients on earth, you know, our children, is something that can be enhanced by, you know, the digital solutions that are out there. But we had to get really creative to make sure that these digital solutions available to you, the pediatric providers, actually made practical, functional sense, because we definitely care a lot about the safety, the cost, and the results of these procedures. And we want to make sure that we're not focusing on one of these aspects without also, you know, focusing on the rest of them, because it's all part of the same equation that results in a better way of doing things. So I don't need to lecture to this audience necessarily about how chronic the caries disease state is, especially in children. You know, it's the most chronic disease of childhood, and, you know, upwards of, you know, almost half the kids in the world, or in this country at least, have cavity problems, tooth decay problems by the time they even start school. And there's a lot of reasons why, and we can debate that for the next several days, I'm sure. But also what doesn't need to be dwelled on necessarily, because Dr. Tam did a great job kind of taking through, the clinical presentations and the procedures to get to optimal results, like what you see here with the various materials and procedures that go into it. But the point I want to make is just how common these things are. Again, I mean, there's a lot of crowns that are done every year, and the projections from a couple of years ago and a couple of years in the future is that we're going to be doing millions and millions and millions and millions of these things, and they're not going to go anywhere anytime soon. So seeing that this is on the uptick, unfortunately, we hope that we can enhance the solution outcomes and the success factors for all these little kids that grow up to be the next generation of adults that is then turning around to do the same better treatment on their children. So not to dwell on the science, but not to overlook it entirely, there's a lot of articles out there that we could quote on, the up and coming factors that relate to the gingival biocompatibility of, the zirconia alternatives to the stainless steel crowns. And Dr. Tam touched on that a little bit. The wear resistance we saw in some of his later slides, how some of these stainless steel crowns can open up like tuna cans, as he put it, and perforations are a real problem. We don't necessarily see that same sort of issue happen in these zirconia alternatives. But most obviously, they're tooth colored, right? And that seems to be the driving reason why we are exploring better materials, better options, because the demand out there from most parents and children is that they want to kind of forget that they had this type of dental problem, and they'd like a natural solution to fit into the reality of their smile and not just be a dead ringer for that issue I had last year or the year before. Because there's a stigma associated with this stuff. I mean, little kids on the playground, they're pointing at each other, even in pre-K. One of my 5-year-old's friends has 9 stainless steel crowns. One of them is on a mandibular cuspid, and it's a pretty visible thing, and he'd rather not have that there, and his parents would rather him not have that there. But the complexity and the pain points that go into providing zirconia crowns in every clinical situation are real, and we have spent years now trying to unwind and understand exactly where the barriers are between these pediatric patients and what many would consider to be a better, more optimal solution in every regard. So it's a function of proper crown size selection, and the tolerances for being kind of like a half size or a full size off when it's a zirconia crown versus a flexible stainless steel crown is quite unforgiving sometimes. And then we're all finding that people are a little bit hesitant to overly aggressively prepare these teeth and maybe do pulpotomies that are arguably unnecessary given what you could do conservatively with a stainless steel crown in many applications. But really it's kind of how do you schedule around some of these zirconia crown procedures, given the extra preparation you do, the extra pulpotomies you may have to do, the extra crown try-ins and size selections and all that stuff that just consumes extra minutes you may not have in that operatory or that OR. And a lot of these zirconia crown procedures, they turn into schedule wildcards because you have them scheduled for 20 minutes and then 90 minutes later, you're still not done with this thing and your day is going sideways. So, kind of in a clean environment on a typodont, just kind of going through some of the motions. I don't need to teach this crowd how to prepare for, say, a stainless steel crown, and arguably not even for some of these zirconia crowns. But because in dental school, myself included, all we ever trained to do in the pediatric part of the clinic was, fit a stainless steel crown. We come out of school thinking we know how to prepare teeth for prefabricated crowns, but when it's a zirconia crown and not a flexible metal crown, it's a whole different animal. When you prep your tooth in a way you think is adequate and you start reaching into the box to try in crowns, no matter if you actually selected the right size crown, it may not seem like it's the right size crown because your preparation geometry is holding it up, but exactly where is it holding it up, you don't know. So you reach back into the crown box and try in another one. That doesn't fit, so you pick up the handpiece and you start adjusting the tooth where you think it's being held up, but also kind of everywhere else at the same time, and you're further reducing. You're trying on more crowns. Maybe you're pushing hard and you snap one of these in half, and that cost you a little bit more in overhead replacement, supply replenishment, and it's still not fitting. And now we're well past the time scale that we should already be done handing this kid a sticker and talking to mom on the way out the door for a post-op check. It's still not there, and we're getting a little bit foggy in the safety glasses or the loops, and our ears are turning red because it's highly frustrating. And maybe this kid is starting to lose it a little bit if they're not necessarily sedated. Maybe they are sedated, and you're wondering, how much longer am I going to have to keep this kid under until I'm done with what should be a very simple procedure. So something that should ordinarily take maybe 2 or 3, maximum 5 minutes, sometimes at least doubles and sometimes triples that sort of procedural time. And how beneficial is this at the end of the day? If we're having to schedule and not just throw our day out of whack, but put the burden of extra sedation time and extra patient compliance and behavior management issues on those children just to accomplish these results. That's why I think they're not necessarily offered as first-line treatment most of the time, especially for posterior teeth. So the time, the crown size selection, and the tooth preparation are what equate to what I believe to be an unfortunate circumstance where we really can't deliver what people want. What do the children want? What do their parents want for their own children? What would you want for your own kid if there needed to be a crown done in their mouth? Would we really want, even on a back tooth, if we had all these things under control, would we really elect for the stainless steel alternative that's been around for 60, 70, 80 years? Maybe, maybe not. Now, to kind of unwind some of those issues, when we look at things a little bit more diagrammatically here, we've got a thin metal shell of a crown. That's what we're used to fitting in there. We're used to conservatively preparing these teeth and basically squishing that flexible metal shell into place. So where it binds between teeth, okay, not too big of an issue. If we've got something reasonably selected as far as the proper crown size, that kind of squeezes into place. And if it's a little bit high, well, guess what? The occlusion kind of squeezes that into place, and it bottoms out on the preparation, and you usually can fit something in there with minimal reduction and minimal specificity as far as the crown size. But when you try to substitute that thinking with a zirconia alternative, well, right out of the gate, we have to reduce the tooth a lot more because these crowns are inherently thicker given the minimal material requirements to keep zirconia from fracturing. So while these things are 0.3, 0.5 millimeters thick, we have to reduce the tooth 2 or 3 times more just to get the ideal preparation done. So that could be a little bit more encroaching on pulp. Maybe we just elect to do pulpotomies right out of the gate. But most of the time we try in one crown and it doesn't go in between the teeth, or at least we think it doesn't go in between the teeth. Maybe it's binding on the prep. We really don't know that for sure until we try in a few more and say we pick a smaller one because we can actually see it binding. And now this one will go in between the teeth, but it's high centering and rocking and binding on the preparation. Exactly where that's occurring, we don't really know. So what do we do in that instance? We take our handpiece out and we reduce the tooth even more, try to be conservative, but we're getting ever closer to that pulp chamber and getting into some endodontic territory. Maybe we could have avoided if we were doing something, arguably more conservative. So then, the opposing teeth come into the picture, and that kind of binding, especially if it's a rock and a hard place situation, the zirconia that's high centering between the occlusion and the preparation, sometimes a little bit more prone to fracturing if you leave it high. Dr. Tam was good to point out that, a little bit of hyperocclusion, as long as the crown isn't binding, should equilibrate over time, given the physiology of the pediatric patient. But we do have to get it in the ballpark, that's for sure. So you start to do more than one of these in a posterior segment or really anywhere in the mouth, and it turns into a compounding series of complications that causes those of us that have tried this to really shy away from it. That's why we still see these metal teeth in the kids' mouths. And if we see the white alternatives, we see them on the anterior teeth with stainless steel in the posterior. If we do see posterior zirconia crowns, it's usually just one. And if it needs, if there's a 2-treatment tooth requirement, it's usually kind of a 2-tone application where the stainless steel is on the second molar and we focus the cosmetic treatment on those first molar sites to keep the complexity to a manageable minimum. That's the goal. but that's been the goal for a long time. You know, we're really talking about procedures that have been done in dentistry for decades and decades and decades. And you could go ahead and probably round it up to a century at this point. And think about today's world we're in. How many things have been done for 50, 60, 70, 80 years that haven't been dramatically updated, just maybe in the last 5 or 10? So we're at a tipping point. We're reaching a technological threshold where the section of dentistry that is last to the technological revolution sometimes, in this instance, maybe could be leading the charge because it is a different generation. My dad was a pediatric dentist, and I grew up around this entire environment. I mean, I was the patient, I was the assistant. And, you know, I got my hands in the mouth in the mid 80s. You know, I like to joke around that I've been a dentist for 35 years, so you can take me seriously. But, you know, I went to dental school myself, and I went down a different pathway into prosthodontics. I was a little bit geeky about the technology and latched onto a lot of this stuff pretty early on. And, you know, maintaining my relationships and my familiarity with pediatric dentistry and my friendships with the pediatric dentists in my life, you know, talking about technology, it just has been hard to find a foothold, a practical way that it actually benefits pediatrics in the same way it benefits prosthodontics or restorative dentistry. But these scanners, now that they aren't all, you know, $50,000, $60,000, $70,000, maybe they're a little bit more affordable. Like Dr. Tam said, even the more affordable ones can actually function faster and be smaller and all the other things that are necessary for us in a more high-paced volumetric practice environment to actually utilize on a real world level. But we in dentistry, we're used to things like milled zirconia and digitally CAD/CAM restorations. And now we're getting more used to things like additive manufacturing and all that stuff that I got familiar with through prosthodontics. I think finally we're at the doorstep of pediatrics latching onto some of this too. And don't get me wrong, I didn't learn a lot of this in school. And I realize I'm talking to an audience of dentists out there that also didn't learn a lot of this in school. I think in most residencies, they're getting exposed to pediatric zirconia crowns, but they definitely are still being steeped in the stainless steel restorative procedures because that's what we expect that even the now generations are going to get out there and do predominantly. So it's one of these things that I've had to learn a lot of this technical digital dentistry stuff on the fly, in the real world, in my spare time outside of the clinic, and sometimes right there in the clinic, just testing things out and trying them. Latching onto the right stuff early can be a huge boost to your practice efficiency and your practice marketability. And I've seen that affect my prosthodontic practice for years now. Because years ago, when we first got into actual functional intraoral scanning and doing all this fancy, you know, digital smile design stuff, we're doing virtual wax ups now on full arch reconstructions, and we can showcase results before we even get started because of, you know, photo and 3D model alignment in the computer software, and arguably very similar software that we're now leveraging for the pediatric protocols that I'll get into in just a minute. But this is kind of where it's come from and why, because we see tremendous benefit to the consistency and results, the marketability of the branding of our practices, because we are now showing patients not just future technology, but the future of what the procedures will, you know, yield for them and their lifestyles and their goals for themselves, because we can take things out of the computer through milling and 3D printing and all these production modalities that keep all this fancy computer stuff right there in the palm of our hand. And we can deliver these types of results, stay consistent from the beginning through the middle, all the way to the very end on something as complicated as a full arch reconstruction dental treatment plan. And again, it all comes from the basis of three-dimensionalizing the teeth through these now very accessible, very affordable scanning instruments like these intraoral scanners we use. Now, when I sit down to say do a full arch reconstruction, what do I care about? Well, I care about the same things that you guys care about when you're doing a prefabricated crown. I have to know exactly like where to reduce the tooth and how much, but I think about it a little bit more Inversely, because I'm doing indirect restorations most of the time, I have to prepare the tooth for known material thicknesses and then customize the crown to fit that tooth for insertion later. And, you know, even though we do all this stuff super fancy and in the computer, guess what we still use most of the time? The same kind of putty stents and reduction guides that we learned how to make in dental school. So even those of us that have these scanners and have been using things like digital dentistry for a long time, we still kind of go back to basics. There still are some kind of up and coming alternatives to the putty model, but exactly how valuable these things are. I mean, a 3D printed reduction guide is basically still a physical thing you put on the tooth to look, see with your perio probe to, you know, assess whether or not you've reduced enough. Hardly, you know, a 21st century solution to a modern day problem. Even though we can actually see cross-sectional reductions on the computer and actually put a little bit of a colorized, intuitive heat map or reduction guidance right over the teeth relative to these full mouth reconstruction plans, that's kind of what we're getting into now, but we're not even quite there yet in the world of prosthodontics. So let me back up and kind of introduce you to my partner, because I've been focused on prosthodontics my entire career, but my buddy, Dr. Davis, is a pediatric dentist, and he did all this training at VCU, again, you know, 10, 12 years ago, learning mostly that we're going to be doing stainless steel crowns when we get out into the real world, even though we are square into the 21st century. He did some of the early research on the zirconia alternatives that were coming out at the time, has been trying to integrate those further and further into the private practice setting. And now that he has multiple brands and providers and all these other perspectives on growing a business around differentiators and provider calibration and all these things, he's trying to get everybody to lean into zirconia crowns, just basically from a business management perspective, because he knows that the results are better, the results are more desired and asked for, and pretty soon will be demanded from the public, and he needs to make sure that his providers are able to deliver on those patient expectations, because zirconia crowns, for all the reasons, and you can have your own judgment on this, are better than the stainless steel alternatives. They're just not any easier, unfortunately, which is why we still see mostly metal teeth, especially in the posterior segments. Dr. Davis also teaches a little bit at some of the residency programs there in Tucson, Arizona. And like a lot of academicians, when you are teaching, you know, up and coming pediatric dentists how to tackle certain clinical cases, and they all want to do these white crown alternatives because those patients' parents would rather have those than the metal ones, you have to hedge your bets. You have to be careful in how you manage your patients or your patients' parents' expectations, because even though they may want the white tooth alternative, you shouldn't probably ever guarantee that you're going to escort the patient up to the waiting room at the end with that white crown installed, because sometimes you have to default back to the stainless steel crown in certain instances. When you're going to try this, you're best to just try, you know, one single crown at a time and not try to convolute the approach with a, you know, a grandiose idea that this whole mouth is going to be made out of zirconia crowns. So just try them one at a time, try to limit it to the anterior sections where you have a little bit more control over things. And make sure you get reimbursed or you charge adequately for it, because you know it's going to take you a little bit more time than you typically would spend on a stainless steel crown. And make sure your patient selection is top notch. You don't want to be trying this on a kicker and a screamer. You want to be doing this either on a sedated case or a very, very cooperative patient if they're going to be awake for it. And if you know, a white tooth result is really, really desired, really try to see how far you can get away with composite only before you think you're going to just place a zirconia crown on every single tooth. So what we're seeing coming out of the academic environments is, you know, more and more creative thinking about how we can solve some of these problems. And there's actual research papers out there that demonstrate that just having some sort of like digitally guided visualization of what these preparations entail, so that you're not just flying blind with your handpiece and grabbing crowns out of the drawer to trial fit like a puzzle with the pieces flipped over. You can actually get the benefits just by visually inspecting something that is guiding you on the screen in terms of preparation guidance. When the guides on the screen, like what we do, are actually used, there's a significant increase in how harmonious the preparation forms are versus the ideal reduction requirements necessary for these zirconia crowns. And the amount of tooth reduction is reduced because we're able to focus the attention with the handpiece in the areas that matter versus just globally reducing the teeth unnecessarily and aggressively. And these results from such studies suggest that tooth preparation guidance can facilitate better prefabricated zirconia crowns. So for all those reasons, I think that this new generation of residents and this new generation of pediatric dentists should be exposed, not just from a training and academic standpoint, but something that they can carry through into the real world. But we're focusing a lot of attention and making sure that training facilities and programs see the benefits of the objective real-time feedback that you get from three-dimensionally scanning teeth and virtually selecting with semi-automated crown measurements in the system. That's what this thing does, and I'll dig into the details in just a little bit. But talk about an easy way to objectively show an up-and-coming pediatric dentist where exactly the tooth reduction is necessary, and training them on proper crown size selection and conservative preparation approaches. It's really a nice thing to put in the academic sectors, but it's also nice that it carries through with practicality into that real world, because we're all trying to go faster, to do more, to be better with everything we do. And it's nice that we can go beyond where we plateau with our hands and our eyes alone with technology to help us along. So the technology I mentioned that I've been using for a long time are these intraoral scanners, and we've seen them evolve as fast as any technology. And that evolution has carried costs down, capabilities up. And now we have a litany of intraoral scanner devices that can all do very, very high quality, quick scans. And we can have data available now in real time, thanks to the software that is integrated into the scanner that we have launched this with. So Alphabyte is a software module that lives integrated within the intraoral scanner platform, okay? And you scan your tooth, it automates the selection of the crown process. It gives you that visual reduction guidance that allows you to achieve better harmony and more conservative tooth reduction. It allows you to even find out exactly where your crown may be hung up if it doesn't seat the very first time, until you can actually get it seated passively yet retentively to achieve that desirable, durable result that every patient deserves. So the scanning, the scanner that we have here is called the Heron iOS. It's made by a company called 3Disc. It's a US-made scanner hardware platform that's good for scanning all kinds of stuff. I mean, I'm a prosthodontist. I don't do a whole lot of prefabricated crowns, but I do a lot of indirect crowns and implant crowns and dentures and partials and even clear aligners sometimes. And this is the kind of scanner that can do all of those things. This one just happens to be the one that also has our Alphabyte computer module integrated into it, so you can use it during the course of a rapid procedure like a prefabricated crown. Because we have now, I think for the first time ever, a pediatric dentiform to select from in a scanner interface. So, if we need to treat tooth B, say with a prefabricated zirconia crown, we can select tooth B, we can immediately start scanning. And usually in about 10 seconds of scan time, we can have enough data to start our prefabricated crown procedure. Normally if I'm scanning for clear aligners or an indirect crown, it's probably a couple of minutes of scanning, followed by a couple of minutes of computer processing time until I can actually do something with it. But what you just saw, that within 20 seconds, 24 seconds, we are ready to start doing the Alphabyte treatment planning and selecting for a crown. So the scanning doesn't consume that much time. You don't have to set aside or really schedule anything any differently than you normally do for a crown procedure. This fits well within the timescales of the existing practice model. So once it's scanned and you have real-time availability to that data, we can run our automated crown size selector just by simply clicking the middle of the treatment tooth. And we know all the geometries of the kinder crown options for these prefabricated zirconia crowns, and the computer system cycles through every possible size given that tooth location and finds you the best fit crown option for you to visualize, and then guide your procedure through achieving that in real time in a single day prefabricated approach. So just by simply clicking the middle of that treatment tooth, In just a few seconds, it'll cycle through, like I said, all the possible crowns and throw one up into the picture for you. And it's usually a pretty appropriate crown size, even though you're not locked into that. You are the provider, and it prompts you on how to optimize and validate and maybe even modify this initial proposal to better align it, to better size it. If you want to deviate from what the computer proposes, that's entirely up to you. But what you get to see are all the angles you can't see in the mouth, plus with the objective feedback of computer measurement run in real time thanks to AI. It's learning and getting better with every case that you do. Now we can see that, we can confidently, assess that, before we even start, a DU 5.5 crown out of the Kinder Crowns drawer should fit in this case. So that lets us do a couple of things. It lets us see, okay, well, one, what do I have to do to this tooth to make sure that DU 5.5 actually fits? So what you see in the upper right that's happened and is available right there in real time is that visual preparation guidance that we see scientifically allows people to do things faster and more conservatively and more effectively than ever before. Should be relatively intuitive, I believe, because as you see the color coding scale in the upper right corner in kind of small print, everything that's red requires 2 millimeters of reduction. Everything that's orange is 1 millimeter. Everything that's kind of yellow is, half to 0. And everything that's green, blue, and purple requires really no reduction at all. So for the first time ever, we can see that there's, probably 40% of this tooth that we don't even need to touch with the burr to get this appropriately selected crown size to fit down there. Now we can be very conservative, way more conservative than we ever thought we could be with a prefab zirconia crown. That's for sure. But we can also see that, okay, do we even have a DU 5.5 in our crown inventory? Can we check the drawer ahead of time? If we don't have it, maybe we can upsize or downsize the crown and see what that does to the preparation requirements. And, maybe we have a 6 or maybe we have a 6.5. Maybe we have to upsize it a little bit. Does that even fit in between the teeth? Are we going to be confused in the middle of this procedure? It is wonderful to know the answers to all of those questions before you sit down and get, up a creek with no paddle, so to speak. So, just like the putty stints that we are, all trained to think to use, and the cross-sectional diagrams from our dental textbooks from dental school, you can run the same sort of analytics right there in real time. You can run cross-sectional sliders across this tooth and get really granular with how much reduction down to the 10th millimeter if you want to. But really, it's a reference point. It's a visual check-see. It's kind of like having the cheat sheet to the test right on the computer screen before you sit down to do the thing. Because when you pass the burr across the tooth, you want to be able to see, not just like before you start, but you want to be able to see where those issues are after you've made your first pass attempt at a preparation. So if you're like me, you remember going up in dental school labs to your professors after you did your first crown prep and them taking some markers out and coloring on all the problems that you left behind. That's exactly what Alphabyte does. In very short order, if you've done your first pass preparation and your ideal crown size that it selected for you doesn't fit, it doesn't necessarily mean that you've got to go try in 3 or 4 other crowns. That is the crown size that should fit in there. So it leaves one variable on the table, that is your preparation. So rather than leaving you high and dry and hanging you out there just to guess as to where the hangups are, pick up the scanner, and 3 seconds later, we can tell you objectively exactly where the high spots are, where the high centering is occurring, where the future sites of fracture propagation are going to occur, and exactly what you need to do to correct for that problem and get that ideal crown to fully seat appropriately. So what we do is we have a button right in Alphabyte that launches the scanner again, and in about 3 seconds of intraoperative preparation scan, we rerun the same program and it automatically re-imports into Alphabyte, and we can see exactly where that preparation is hung up. So this is our first attempt at the preparation. I thought I did a good job. We thought the crown would fit. Guess what? It didn't. It's not because it's the wrong crown size. It's because I left the mesial and distal line angles and some of the occlusal corners under reduced, and then, diagonally across the mesial buccal and distal lingual, those axial walls need to be reduced. It doesn't mean I need to go back in there with the burr and turn this preparation into a toothpick. It doesn't mean that in the middle of the procedure, I need to do a surprise pulpotomy because I've hollowed this thing out. It doesn't mean that I have to spend the extra time to do any of that stuff. I just have to very efficiently and in a focused way reapproach this tooth in the areas that are lit up in red, orange, and yellow until my crown actually does seat. So now we can go in with confidence and we can apply these alternatives to metal colored teeth and the perforation problems and all that stuff. We can now offer these more desirable solutions, not just on the front teeth, but also in the back teeth. And like Dr. Tam alluded to, we're having multi-crown functionalities as features that are rolling out. And we plan to take this software and this capacity well into the future and as fast as possible so that we can do as good as possible, as soon as possible for everybody out there. So you might be thinking, how do I possibly incorporate scanning these kids in my practice? Well, you know, if you're a pediatric dentist and you would sedate or honestly have an OR on site or even at a hospital, this is a very portable system, runs off a laptop, and it comes in a little suitcase if you want to take it around town. But you can also scan at the recare appointments. And scanning a kid is not that hard to do, especially if you're just doing segmental scans like we showed. It takes about 10 seconds and it's not a very scary thing. A lot of kids think it's rather fun to do, but I understand that sometimes you're not even going to have the time to spend an extra minute during that recare appointment. So that's why we developed this real-time functionality where you can scan after the kid is sedated, right there in the OR, and you don't have to pre-process anything. You don't have to send anything to a lab. You don't even have to wait on the computer to really think very long. It's instantaneously available on the computer screen, maybe while you're getting the rest of the instrumentation and materials set up to begin the procedure right after they're sedated. So if you're going to do an awake case or somebody on nitrous, you know, after you inject your local, you can go do 3 or 4 hygiene checks, come back, and maybe your assistant's already done some of the tee-up steps, and you can verify that the crown on the computer screen is of the right size, is in the right place, and then you can sit down and begin the procedure. Or if you're going to sedate the case while you're setting up anesthesia, materials, and instrumentations, pick up the scanner, spend the 30, 40, 45 seconds doing the treatment planning on the computer, and hit the ground running right away. So obviously, why you would want to scan? Well, you know, the whole point here is that we can facilitate the prefabricated zirconia crown type procedure, but that's definitely not the only thing that these scanners can do for you. And if, again, you're in a pediatric environment, maybe you're interested in doing some indirect space maintainers. I mean, instead of alginate, this scanner does all of that digital impression taking and can become a funnel, a case transmission instrument to send digital data directly to a digital laboratory for indirect restoration design. Clear aligners, same way. Just scan the case just like any Invisalign center would, and send it on to your lab for clear aligner production. Same with retainers, as well as all the things that I do, from the adult crowns and the implant crowns and the dentures and everything else. It functions just like any other intraoral scanner that can do a good job quickly and affordably all at the same time. So this scanner itself, like Dr. Tam mentioned, it's of a pretty good form factor. It's light, it's small, which is great for the pediatric applications, but even on the adult patients, it's fully capable of scanning for all the things I just mentioned, and really only takes a couple of minutes to produce high quality data that can be digitally transmitted to any digitally capable lab. But again, in the pediatric sector, this is just kind of a video example of how the process goes. You know, after the local anesthetic is administered, while we're waiting on that 5-minute, you know, set-in time or whatever, that's when the scanner gets picked up. That's when the computer gets activated. That's when the automated size selection algorithms are run. That's when the validation of the automatic proposal is completed by the provider. That's when the pre-selected size is identified in the local crown inventory. That's when the initial kind of cheat sheet is up on the screen for the tooth reduction guidance. And by the time you've finished clicking around on the computer for a minute, you might still be waiting for anesthetic to set in, go do some hygiene checks, come back, pick up the handpiece, and begin the exam with the cheat sheet on the screen. So you're likely to, like the science shows, be able to achieve a more harmonious tooth preparation more conservatively, more efficiently, and with a whole lot less guesswork in terms of getting the crown to fit at the end of the day. So, you know, there's a wide range of people, I'm sure, paying attention. Hopefully there is. And I would just ask you, you know, if you're a pediatric dentist, you know, you're obviously receiving mostly pediatric patients, and you do these procedures day in and day out. But you may not be a pediatric dentist. You may be a general dentist that is doing a wide swath of dental treatments and need a very capable range of uses for your technology. And that's what this really affords you. So if you do see some odd children, here or there, 5 or 6 cases a month, or maybe you do 50 cases a day, who knows exactly what your practice volume is. But I just want to kind of ask all of you, where is your own standard of care? Where do you see your own practice brand standing in society at this point in 2023? A lot of us gave up doing amalgams 20 plus years ago. We're doing composites because we're an amalgam-free practice. We want the white tooth-colored filling material, and literally every patient out there agrees with you. We gave up doing gold crowns, even though those are the gold standard still, for these cosmetic alternatives, these indirect Emax or Bruxer type zirconia crowns for adults. This is very commonplace, and honestly, it's pretty rare that we see any kind of metal used on an adult patient for restorative purposes. And it's still, increasingly rare that we see metal used in orthodontic applications. I mean, we're looking for cosmetic solutions and able to offer them to our adult patient population. Why are we not doing the same thing for our children, the children of those same patients in those same practices? Let's offer this 21st century option to as many patients as possible, but not let a lack of technology hold you back from that. So finally, what we hope that we can bring is an opportunity for pediatric dentistry to get on board with the digital age of dentistry. And maybe for the first time ever, have a chance to lead the pack in this direction, because I think technology like what we're bringing to the prefabricated crown procedure can impact even the prosthodontics that I might do in 3 to 5 years. And we're working on solutions for that as well. So you heard from Dr. Tam earlier this morning, and he's been doing a great job helping us beta test some software, and we're getting lots of good feedback from him, practical applications, clinical indications, all that kind of stuff. We've got a lot of other users out there, and if you know any of these people, you can reach out to them and read through some of these feedback responses on the Kindercrowns website. And I urge all of you to come see it for yourself, whether that's a remote, kind of like a meeting that we could set up, or maybe some sort of live training or some sort of hands-on course at some conference. If you see us at the booth, come stop by and check this thing out, because it really is magical how quickly it works. And we hope it's as magical in terms of how much of an impact it makes on your practice as well. So I'll round it out there and stick around if there's any questions. I'd be happy to talk about it.
Great, thank you, Dr. Johnson. Yes, we will definitely take questions in the chat. If you wanted to speak your question, I need to allow you to talk. So please raise your hand if you do want to ask the question out loud. Otherwise, please put a question in the chat box. And I'll also ask Brandon to join as well. Before we conclude the CE, I wanted to leave it open for questions. Here we go. Oh, I have one that popped up. Can the Huron 3-disc system be utilized for custom restorations or orthodontics?
Yeah, absolutely. Clear aligner orthodontics, study models, probably indirect bonding trays and appliances for bands and brackets. It just depends on, the laboratory resourcing that goes on in the background. I'm pretty sure that, through Kindercrowns specifically, there are orthodontic resources right through that same laboratory channel. So everything that can be done with digital impression data can be done with this scanner just like any other. Now, the only thing that it doesn't do is quote unquote branded Invisalign, because the only scanner that is allowed to do that is the Invisalign scanner, that is the iTero scanner. So there are all kinds of alternatives to other clear aligner manufacturers and treatment modalities. And I just say, hey, look at what value you get out of the range of options, and contact the lab guys to see what they can do with it.
Great, thank you.
Hey, what? Before I forget, let me address that other question that was posed at the end of Dr. Tam's, because the whole assistants taking final impressions. I believe in my state of Arkansas, that's the prohibition there too. I don't let my assistants take final impression scans for crowns or implants or anything. I do all of that myself. But Alphabyte is a little bit different. It's a lot more like where you would deploy an intraoral camera, much less an intraoral scanner, because we're not using Alphabyte data for anything that the laboratory would process or turn into an indirect restoration. The restoration you're installing is right there in the drawer. So I would think about utilizing the Alphabyte scanner in the same way that you would deploy and delegate the use of your intraoral camera. It's really just to get information on the screen that helps you, the provider, make a treatment planning and diagnostic decision in real time. And I don't believe that there's any issue with the assistants doing the preparation scans or the pre-op scans. Most of the time, the doctor is going to sit there and do the actual preparation scan anyway, because it takes exactly 3 seconds to do that. So I don't know that there's any kind of like medical legal barrier to, you know, anybody in the office actually wielding the scanner in this Alphabyte type procedure. So I hope that clears that up.
Thank you for talking more on that. We did have another question come through. Thank you, Dr. Johnson, for your time. How big is the wand compared to an iTero scanner for pediatric mouths?
You know what? I don't have an iTero right next to me, but you know, the wand on this Heron scanner, I mean, it's at least maybe 20% smaller if I was going to put a number to it. So it's a lot more the same size and shape of, say, a Trios scanner or a Medit scanner or something you might be more familiar with. It's you know, probably about as big as your thumb when you put the tip on there. And we haven't had any cases that have been you know, impossible to scan. The good thing about the data requirements from the scan is that, I mean, we want it to be a good scan, right? But it does not have to be a perfect scan. You don't have to spend 3 or 4 minutes trying to fill in all the little nooks and crannies and get around all the undercuts. We just need a 10-second representation of what the basis, you know, geometry is of this treatment tooth space, a tooth next to it, behind it, a tooth in front of it, and then the computer system can run on even pretty problematic scan data most of the time. So I think efficiency greatly outweighs any complicators you might encounter using the scanner.
Great, thank you. Let me just monitor the other questions here. We talked about that. Somebody chimed in that they agree it's not a final impression. I don't have any other questions other than there was one about the approximate cost, which I would like to address once the CE, the education part is over. We just need to adhere to the requirements of our giving our education CE credits. So before we address cost or any other topics specifically about Alphabyte, I will go ahead and conclude the education portion of this webinar. And I will give the code here again. Again, I will be sending out a follow-up email to everybody that attended with the recording of today's session, along with the code, and then, or I'm sorry, not with the code, because we will be sending the survey that you need to fill out and put the code at the bottom, and then send that back into us at info@apexlabgroup.com. And then we will process that and send you your CE credits within about 30 days. And again, that code is TJ0210, TJ0210. And I do have another question that came through for you, Dr. Johnson. Are you doing anterior crowns?
Oh yeah, great. That was the other thing. Thanks for bringing that up. Yes, Alphabyte can do an anterior crown just like a posterior crown. All the anterior kinder crowns are represented in the digital library. You can be cycled through given that those tooth locations just like anything in the posterior. So that is definitely an option that is built into the feature set right now.
Great. I'm going to check one more thing. Brandon, why don't we turn it over to you and provide some more information on the different crown options that Dr. Tam had mentioned earlier on?
Sure. As you mentioned, for anteriors, there's a contoured and a universal version. Universal being ambidextrous, so it could be used as a right or left. For centrals and laterals, most of our clinicians use the universal. It's half the inventory. Generally, if you're placing one crown, you're probably doing all 4. So it actually evens out. You don't really need that rounded distal corner. Now, if you do want to order contoured, you can certainly do it. You're just going to have basically a crown that's specifically for that tooth. I do have some that only order universal, and if they do a single anterior, they turn out nice. Just like with a composite crown, you can round a distal. You're just going to want to use a zirconia adjustment diamond for those types of cases, and then you're going to use a two-step polishing system, a medium and a fine grit. For canines, well, centrals and laterals are available in sizes 1 through 6. For canines, they're available in sizes 0.5 through 6. So there's a mid-size for those. So if you have space loss, you're trying to put in centrals and laterals, sometimes getting canines in can be a challenge. So 6 across is a big case. It's nice to have a kind of a cheater crown that, simulates squeezing of the stainless steel. Those are also universal. All of our canines are universal for uppers and lowers. We do have lower incisors available. Lower incisors are sizes 1 through 4, which is pretty consistent with what you would find with strip crowns, what you'd find with just regular stainless steel crowns. We try to mimic, not really mimic, but stay consistent with the sizing of other available options. So when you're going to place these, it's more familiar to you when selecting a size. Now for posteriors, Dr. Tam has switched, as he mentioned, over to our universal version back in 2018 when we launched. Essentially, the way that was designed is, again, to be ambidextrous. You can use it as a right or a left. So you don't have S and L, you just have a D lower. The universal and contoured, if you want to go that route, for posteriors is available in sizes 1.5 through 7. He showed a few cases where he needed a smaller crown size. So when you go to order kits, the most basic kit you can get is sizes 2.5 to 5. 2.5 to 5 is going to be the majority of what you're going to be using. But there is going to be patients out there that, you're going to need a 1.5 or 2. So you don't have to, modify the adjacent dentition to try and get it to fit. Sometimes you're going to need a size 7, and you don't want to put a 6 on there because then you're going to have to over reduce that tooth to get it to fit. So having a full range of sizes is really important when purchasing, when ordering a kit. Obviously you can go a little bit heavier on your inventory within that 2.5 to 5 range, which is common, but definitely order a little bit of those uncommon sizes. Now, if you run into a case where a 1.5 is still too big, then you can contact us and say, hey, can you create a size 0.0 or 0.5 or a -1? If you give me dimensions of what you would like us to manufacture, we can certainly just modify a kinder crown that's going to fit within that interproximal space width. Now, if you are going to send us a custom crown, you can certainly use the scanner. We do those very frequently at our lab, and if it's something that's out of our wheelhouse, fortunately we have all the Apex partner laboratories that we can utilize to take care of your needs.
Great, thank you, Brandon. And I've shared my screen as well, just to give a quick overview again of kinder crowns and how it fits into the Apex world. Apex Dental Laboratory Group is comprised of 20 different laboratory partners. Like I said at the beginning, we're located across the US in a lot of different territories and regions, including Alaska. And I have those listed on the right side there. Quite a few in the Midwest, and possibly more to come. So if you have any questions, please go to those 2 websites. Those are links down at the bottom. You should be able to click on those to go directly to the website for any questions. And I know Dr. Johnson had a QR code on his slide as well. But I will send the link out when I send the recording. So if you have any other questions, let me just double check that there are none listed. I believe that is it. Well, thank you, everybody, for your time. We had everybody pretty much stay on the whole time, which is great. And thank you for your time, Dr. Johnson and Brandon as well. Everybody have a great weekend.
All right, thanks everybody. Enjoyed it.
Thank you very much.
Bye-bye.
Bye.